Welcome, Katikar ma'am.
Hello, good evening, Vaishali.
Good evening, ma'am.
Good evening, ma'am.
Good evening, good evening.
Good evening, Manisha. Good evening.
Good evening, Maya madam. Good evening, Kakatkar sir. Good evening. खूप दिवसांनी दिसतंय.
Good evening, sir.
सर नमस्कार, काकतकर सर.
सरांनी म्यूट केलंय बहुतेक.
म्यूट केलंय सर.
हा, म्यूट आहे.
कमला मॅडम पण जॉईन झाले.
यस मॅडम. गुड इव्हिनिंग.
हा, अमला मॅडम पण. मॅडम कॉफी घेतात, त्यांना शांतपणे घेऊ देऊ.
हाय.
वी कॅन स्टार्ट आय थिंक ना. आपण चालू करूया.
येस, म्हणजे इंट्रोडक्टरी पार्ट वगैरे होईल ना थोडा.
येस येस, या वी कॅन स्टार्ट आय थिंक.
Yes, madam.
चालू करा, मनीषा चालू करा. गुड
Yes,
इव्हिनिंग
yes,
एव्हरीबॉडी.
गुड इव्हिनिंग विनायक सर. गुड इव्हिनिंग.
Okay, ma'am. Then should I start?
या प्लीज प्लीज.
या.
Okay, thank you, ma'am. Good evening and a very warm welcome to all the respected seniors, office bearers, esteemed speakers, and delegates for today's webinar on intraoperative catastrophes. To begin the webinar, I request President Society of Anesthesiologists Pimpri Chinchwad, Dr. Maya Bhalerao Madam, to introduce the programs, followed by Dr. Kavita Nivargi Madam to say a few words. Maya Madam, please can you introduce the program?
Good evening and a very warm welcome to MSc ISA Office Bearer President Manisha Madam, Secretary Avinash Sir, all eminent speakers and dear delegate friends. Today, for the first time, 2 city branches have jointly organized this webinar. In last couple of years, because of easy availability of Zoom platform or maybe other online resources, it has been observed that there is too much of trafficking of webinars and there is clogging up of WhatsApp with n number of flyers. Delegates are being bombarded by various academic topics and even the speakers are overburdened with many presentations and talks. And this is not without the stress of organizing the webinars on organizing team or maybe on the branches. So I thought, why not to go for a joint venture so that both the branches will get the satisfaction of conducting the programs. The workload will be distributed. There won't be any more challenges. How many will log in? Because it is always a problem for us. How many people will log in? And with the same efforts and energy, there can be more beneficiaries also. So yes, this is a small step towards new initiative, joint venture by 2 branches. With this joint activity, we could establish the friendship bond between our 2 branches like SAPC and SAS. We got a platform to exchange our thoughts and ideas and also enriched us with a broader vision. So building a bridge between the 2 city branches, myself, Dr. Maya Bhalerao, President SAPC, our Secretary, Dr. Seema Suryavanshi, my good friend, Dr. Kavita Nivargi, who is the President of SAS, Society of Anesthesiologists, Dr. Vaishali Emul, Secretary SAS, are glad to welcome you and present you today's webinar. So once again, a very warm welcome from SAPC and SAS, and I would hand over to Dr. Kavita Nivargi for further proceedings. Thank you. Kavita, unmute yourself.
Oh, thank you, Maya. It is indeed a very wonderful and thoughtful idea, and it is our pleasure to associate with SAPC, so Society of Anesthesiologists of Pimpri-Chinchwad. Let me introduce to you today's subject and the speakers. We all work up very meticulously during our pre-anesthesia checkup and pre-operatively, and then only the patient comes up on the operation table for the elective cases. In spite of all this, we do come across some unexpected, unpredicted, life-threatening incidences intraoperatively, and I'm sure they are no less than a nightmare. So, intraoperative catastrophe is the today's subject of talk. Intraoperative catastrophes can occur during any minor surgery or a major surgery. It can occur during laparoscopic surgery or any other kind of surgeries. It can be in the form of cardiac events or non-cardiac events, or sometimes maybe due to the technical glitch. So it is our vigilance, presence of mind, and our knowledge which comes to our rescue during such circumstances. And from where do we get the knowledge? Definitely from such academic activities and from the experts. So we are very lucky to have with us today the experienced anesthesiologist to talk on this important subject. I welcome today's eminent speakers, Dr. Amla Kudalkar, Head of the Department Anesthesiology, KEM Hospital, Mumbai, Dr. Vijay Shetty, Head of the Department Anesthesiology, Fortis Hospital, Mumbai, and Dr. Sandeep Mutta, Consultant Anesthesiologist, PAPCL Director and the Director of Medicor. I welcome all the MSc ISA office bearers for joining this webinar. I welcome all the delegates who have joined this webinar with us today. And we hope that we would be able to serve you some good academics today to you all. I'm sure that each one of us would be definitely relate with at least one or more incidences which are being described today to have come across during their own individual practice. So I'm sure we are going to enjoy this session today. Now I would like to have few words from the Secretary MSc ISA, Dr. Avinash Bhosle, and we would really like Dr. Manisha Katikar, President MSc ISA, to share her feelings and view on this. So Dr. Avinash Bhosle. Dr. Avinash Bhosle, would you say something?
Avinash, please unmute yourself.
No, is madam is speaking or Manisha madam?
Avinash sir, आधी तुम्ही बोला मग madam
Okay. Good evening, everybody. Respected office bearers and all members of SAPC and SAS, respected faculties of today's webinar and my friends. Best wishes from Maharashtra State Chapter of ISA. A very good idea of jointly organizing CME. I think this type of combined venture can be tried for physical gathering also, and physical gathering or conference or CME. Even combined holiday trip can be arranged with both branches. We can call it as an exchange CME or like a barter system. Previously, it was a barter system. They exchange the goods, but we can exchange our knowledge and ideas here. All speakers and moderators will be from that branch only, and like that we can arrange this CME or a conference like exchange CME. Also, we can have good new friends with this and chance to explore the new city of that branch. So we can arrange the meeting like this physically. Also, we can arrange combined members or family picnic, holiday tour. So very good motive. Congratulations to Dr. Maya, Kavita, Dr. Seema, Dr. Vaishali, and team of SAPC and team of SAS. Thank you. Best wishes for this webinar. Thank you. Thank you very much. Long live ISA. Thank you.
Thank you so much. Thank you.
Over to you, Manisha.
Yeah, thank you so much, Kavita. Respected faculty for today, Dr. Amla Kudalkar Madam, Dr. Sandeep Mutta, and Dr. Vijay Shetty Sir. It is really nice to have you on my own platform, that is a SAS platform, and another city branch, which is very near to my heart, that is the Pimpri-Chinchwad branch. It is really nice to have you with us, and I must appreciate. I'm sure that Maya and Kavita, the duo friends right from the days of science, they are having excellent ideas, and this is one of the great idea that has come from their own minds, and they have used this platform or utilized this Maharashtra State ISA platform for a great academic feast. It will be a pleasure to listen to Dr. Vijay Shetty again on a consecutive day, and I hope we will have again a meet with him tomorrow also in some more academic feast. Wish you all the best for the webinar. Heartiest congratulations to Dr. Maya Balero, Dr. Seema, Dr. Kavita Nivargi, and Dr. Vaishali for this novel idea. And I'm sure that many more branches will come forward, will utilize the Maharashtra State ISA platform more and more, and we all will get enriched with more and more good scientific and academic content. Wish you all the best. I'm eager, and I'm sure everyone is eager to listen to the great stalwarts today. So let's begin with the academic program. Thank you so much.
Thank you.
Thank you,
Manisha Madam.
Thank you, Katikar Madam, for sparing the valuable time and joining this webinar. Sir, your idea of having a combined CME is really fantastic. So let's begin with our today's session. First, let's begin our today's session with Dr. Amla Kudarkar Madam, talk on non-cardiac events. Varsha, can you please share the slide? Madam is Professor and HOD Anesthesia at St. GS Medical College and KM Mumbai. With over 33 years of clinical experience, she is co-editor of book Practical Approach to Anesthesia for Emergency Surgical Procedures. She has written chapters in anesthesia and trauma books and articles in national as well as international journals. She has delivered lectures in CME and conferences. Welcome, Dr. Kudarkar Madam.
Can I share my screen now?
Yes, ma'am, sure.
Unable to share actually. Has the previous speaker stopped sharing? Has the previous...
Yeah. You, madam, you are the co-host. You can share your screen, but still I'll ask. Varsha, are you there?
Yes, ma'am. Yes.
Can you help? Madam is co-host, so she can share her screen. No?
Yes, ma'am.
Can you just guide her?
Yeah. Ma'am, just click share button.
Yeah.
Then select your PDF file or PPT.
Which is not seen here, though I have minimized it.
Amla madam, minimize naka karu. Keep your PPT open.
First open the PPT and then share.
PPT आधी open करा आणि मग share करा madam.
Oh.
तुम्हाला मल्टिपल स्क्रीन दिसतील मॅम तिथे तर हा येस
मॅडम स्क्रोल करून बघा एकदा.
येस मॅडम होत आहे. चेंज होते.
ओके.
मॅडम पुढची स्लाइड घेऊन बघा एकदा पुढची स्लाइड.
या
आहे.
ओके. मॅडम आम्हाला पहिली स्लाइड दिसते बरं का अजून.
हा त्याच्यात ते हे आहे ना.
सर मॅम स्लाइड साइडच्या इमेजेस चेंज झाल्यात नेक्स्ट बटनला.
ओके.
या ओके.
ओके मॅम.
हो झालेत.
Hello everyone. Thank you Pimpri Chinchwad and Solapur branch for having me here. As well as special thanks to Maya for accommodating my time. And as we go along with the theme, I will be speaking on intraoperative non-cardiac catastrophe. and I bring love from KEM Hospital, Mumbai. Now let's first see what is a catastrophe. It's an event causing great and sudden damage and suffering. In other words, it is plain disaster. I will be dealing with few of the catastrophes that not commonly occur, but whenever they occur, will have devastating effects. Let's consider one patient, 38-year-old male patient who was posted for laparoscopic cholecystectomy. History, examination, everything was normal, except that he's a smoker and he had URTI 4 to 5 days back. Now his chest was absolutely clear. After starting monitoring, anesthesia was induced with injection thiopentone 3 to 4 milligram intravenously. Intubation was facilitated using scoline. Endotracheal intubation was done with number 7.5 cuffed endotracheal tube using Macintosh blade, and however, patient did cough during intubation. After connecting the breathing circuit, there was stony resistance to ventilation. There was no chest rise and complete absence of air entry bilaterally. So there was a dilemma. So parameters remained: pulse, little tachycardia, blood pressure 160, 100 millimeters of mercury. Saturation, initially it was 98%, but within a span of 1 to 2 minutes, it dropped to 80 and then to 72%. EtCO2, strangely, was constant at 5 to 6 centimeters of water, and there was a tight bag when manually ventilated. Severe resistance to ventilation. So let's see what must be the problem. What can be the differential diagnosis? Since there was absence of any chest rise, absence of exhaled mist in endotracheal tube, with EtCO2 falling quickly, and patient also dropping saturation. Inflation of the epigastrium was not seen, but however, it is possible in little bulky patient. So it was probably esophageal intubation. In the NAP4 study, it was mentioned by Dr. Tim Cook that failure to correctly interpret a capnograph trace led to several esophageal intubations going unrecognized in India. A flat capnograph trace indicates that there is no ventilation of the lung. Either the tube is not in place or there is complete obstruction. So just remember one thing, that no trace, that means in the wrong place. If you, as you can see here, this is a normal capnograph and this is severely depleted and it almost reached zero. So we have learned in our undergraduate, in our residency, that when in doubt, take it out. We decided to slightly deviate from it. Since the person who intubated was quite confident of normal intubation, we decided to have a quick look of video laryngoscopy just to confirm the placement, and it was confirmed. So the tube was indeed in trachea. Now what can be the problem? Either there is mechanical obstruction or there is severe bronchospasm. Mechanical obstruction also can cause problem. It can be in the form of kinking, or you must have seen recent Facebook picture, the tube on our task group, that the connector which was attached to the endotracheal tube was completely blocked. There was no hole in that, and there can be the inner fracture of the inner tube. There can be herniation of the cuff which causes obstruction to the opening, and there can be complete obstruction either by the secretion or mucus plug. So all these can happen. There can be blocked HME filter also. Now in this case, it was a fresh case and everything was checked prior. So rarely it can happen, but it is a good practice to check your circuit prior to every patient. Also, alternate means of ventilation should be kept ready. So should you are not able to ventilate using your workstation, an AmbuVac will serve the purpose, and it will be able to differentiate between whether it is patient related problem or the machine related problem. And third differential diagnosis would be bronchospasm under anesthesia. Now, what are the factors which can lead to such severe bronchospasm? Well, allergic diastasis, that is history of atopy, if the patient is asthmatic or COPD, history of smoking leading to irritable airways, upper airway infections, mainly viral. So our patient was a smoker, and few days back he did have upper respiratory infection, though he had clear chest at the time of induction. And the anesthesia related factors would be stimulation of the patient in lighter plane of anesthesia. Now this stimulation could be local, that is manipulation of the trachea trying to intubate, or it could be distal, like cervical or urethral dilatation in the lighter plane of anesthesia. Mind you, a properly placed endotracheal tube, which is little deep in place, that also can cause carinal stimulation and bronchospasm. Use of certain drugs like thiopentone, morphine, which cause histamine, succinylcholine, atracurium, mivacurium, all these are capable of producing bronchospasm. Inhalational anesthetics like isoflurane, desflurane, they cause irritation of the airway, and therefore they can cause spasm. So does neostigmine because of its anticholinesterase action. It causes increased secretion and bronchoconstriction. A simple pathophysiology, not in detail, constriction of the bronchial smooth muscles and mucosal edema will cause luminal narrowing, reduces the radius and increases the resistance many times, and increase the airway pressure. So what would be the clinical features? Prolonged expiration and expirative wheezing. Wheezing occurs when the airflow occurs through a narrow passage. It may be completely absent if there is severe spasm, which does not allow any airflow to occur. There will be tight back and high peak airway pressures. There will be reduced pulmonary compliance, decreasing exhaled tidal volume. EtCO2 increases and there is loss of phase 3 plateau on capnograph. However, EtCO2 may be completely absent if there is again no exchange of gas. As the airways open, the EtCO2 will start rising. There can be hypercarbia and hypoxia, and gas trapping or autopeep on ventilatory parameters you will be able to see. Now let's see the monitor of this patient. You can see that the characteristic square wave pattern with slight upslope has completely gone, and what you see is steep loss of plateau phase and steep upstroke of the EtCO2. So this is shark fin appearance. So EtCO2 is increased, there is proportionate hypoxia, there is tachycardia and hypertension, though BP is not seen here. And on the ventilator, if you see the scalar, the next breath is starting before the completion of the previous. So this is the air trapping that you will see giving rise to auto peep. You can see here there is decrease in the compliance, and this is the auto peep that you can see. So what are the ventilator settings that you must adjust? Of course, give 100% oxygen, deepen the level of anesthesia inhalational anesthetics, slow respiratory rate. Now you have to allow enough time for the exhaled air to escape. So keep around 10 to 12 per minute. Adjust the I ratio to allow maximum time for expiration. I mean, you can accept ratio of 1:4. Higher inspiratory flow rates so that the gas exchange is fast. Eliminating inspiratory pause if possible. Basically what you have to go is you have to reduce the minute ventilation and accept permissible hypercapnia so long as the pH remains above 7.25. And then how do we treat it? First of all, remove the stimulus. So stop tracheal manipulation, stop surgical stimulus. If somebody is dilating cervix, ask the surgeon to stop. Give 100% oxygen. Do not give nitrous oxide so as to have high FiO2. Deepen the level of anesthesia immediately. Now this can be done by inhalational anesthetics as well as intravenous. We prefer intravenous if there is no hemodynamic compromise. Add propofol, which attenuates the airway reflexes, and ketamine, which is bronchodilator. Add around 10 to 20 milligrams bolus, followed by you may start the infusion of 1 to 2 milligram per kg per hour. A bit about halothane and sevoflurane. Though halothane is a bronchodilator and sevoflurane is also not irritant to the airways, since the airways are severely narrowed, there is hardly any exchange of gases. So both halothane or sevoflurane do not, they cannot act. So at this juncture, it is better to deepen the level of anesthesia by intravenous anesthetic agents. Also remember that halothane, though it causes bronchodilator, it also sensitizes the myocardium to the effect of adrenaline. And during the course, you may have to give adrenaline in future. So be cautious about halothane. People have also given intravenous magnesium 40 milligram per kilo, so around over 20 minutes. So usually it will be 1.5 to 2 grams intravenously, and that will relieve the bronchospasm. And one can give bronchodilators like inhaled salbutamol. So they form the mainstay beta-2 agonist. 6 to 8 puffs through the either directly into the endotracheal tube or through the spacer. Now, why inhaled? Because it is acting directly at the site where the problem is. Intravenously, you need to give higher dose, and it causes systemic side effects also. Ipratropium also 0.5 milligram or 6 hourly you can give. Also deriphylline, epinephrine in small aliquots of 10 micrograms to 100 micrograms as per the response. And of course, steroid hydrocortisone 200 milligrams intravenously one can give. But if the problem does not solve, I mean wheezing continues, it may be a symptom of some other different problem at the background, not asthma but something else. So again, check for all the circuits, tubes, etc. Perhaps you are using excessively high tidal volume, high inspirative flow rates. Patient may be obese. Obese patient do have narrowed airways. Patient can have pneumoperitoneum. Remember, the patient is for laparoscopic cholecystectomy. There can be tension pneumothorax and pulmonary edema. Just prior to that frank pulmonary, overt pulmonary edema, you can have pulmonary congestion, and it expresses as wheeze. So all these problems you have to look for. Next catastrophe we come to local anesthesia systemic toxicity. Now these are the, I will just run through these 3 cases. In one patient, it was 52-year-old patient. All of them had, they received supraclavicular perivascular along with axillary block. Everything was given USG guided and after taking all precautions, but in this patient, the analgesia and the motor block was inadequate. Therefore, he was given general anesthesia and the patient was shifted in lateral position. After 40 to 45 minutes, patient had sudden tachycardia followed by bradycardia, hypotension and ST elevation. Immediately followed by ventricular fibrillation, and he had to be shocked. Now everyone was thinking on the line of myocardial infarction because it was 45 to 50 minutes afterwards. And here, since the patient had received general anesthesia, there were no prodromal symptoms like circumoral twitching. So everybody was thinking on lines of myocardial infarct, and probably this patient was also given heparin. This is a patient, she is again 50-year-old. She also received similar kind of anesthesia, but she, after 25 minutes of block, the patient experienced circumoral twitching and uprolling of eyeballs. The patient became unresponsive, and however, there were no serious manifestations. Immediately, intravenous induction and intubation was done. And in her, initially, it was severe that was suspected, and CT scan was ordered, which later on turned out to be essentially normal. So this all happened after a gap of 35 minutes. Last was suspected and injection intralipid was given. The patient improved after that and regained consciousness and was extubated after 2 hours. A third patient, who is a younger patient, similar block, after 20 minutes, patient developed circumoral twitching, tongue tremors and became disoriented. Immediately here, the last was suspected and intravenous intralipid was given, loading plus maintenance dose. Immediately, within a matter of say 20 minutes, the symptoms abated and he was normal. So where lied the problem? In the first case, we did not suspect last early. Here, since we suspected and managed the patient, we could, the patient literally survived. So what are the symptoms of local anesthesia toxicity? Initially, there will be excitation followed by depression. So usually neurological symptoms appear early and they are warning you. Circumoral or tongue numbness, metallic taste, lightheadedness, dizziness, visual and auditory disturbances, disorientation, drowsiness, usually this occurs first. Cardiorespiratory symptoms, usually hypertension, tachycardia, myocardial depression, followed by vasodilatation and hypotension, arrhythmias, and conduction blocks and asystole. There can be respiratory arrest also. A drug like bupivacaine will have cardiorespiratory symptoms early, whereas lignocaine usually causes early neurological symptoms. So this is the difference between the two. Which are the factors that are responsible for toxicity? Block related would be direct intravascular injection. You are not careful enough to aspirate. Injection into a highly vascular area. You have aspirated and checked, but the area is so vascular. This happens mainly in the stellate ganglion region or axillary region, or in the in various other areas like subinterscalene blocks. Needle and catheter placement without imaging. I mean, initially so many cases we have done by just blind placement of needle and catheter. With the advent of USG, I mean, you are not justified to do it. So always use USG. Then injection without a test dose or tracer like adrenaline. Use of large doses. I mean, so many times we give filled blocks like a tap block, where we use really high volume of agent. And these patients can exhibit toxicity. And then single dose versus infusion. While giving single dose, every time you are checking. Infusion, once you start, and if there is catheter migration, there may be problem, of catheter migration and drug going in wrong places. Patient-related factors, extremes of age group. In children, the metabolizing organs and systems are not developed. In old age, their function is diminishing. Liver, kidney, and heart diseases reduce organ perfusion, metabolism, and clearance of the drug. So USG guided, so what I would suggest is always whenever available, USG guided placement and doubly confirmed by PNS, frequent aspiration, giving test dose, incremental injection. Do not give the entire volume in one go. Use smallest possible dose, and this is possible now with the advent of USG. So you are able to go very near the nerve and then give small doses. Use of tracer, and of course continued monitoring. So when we come across these symptoms, what we should do? Stop further injection, of course, and call for help. So we have three areas to look after. First, stop seizures by giving injection midazolam, thiopental, propofol, or regular anticonvulsant for that matter. Support ventilation, oxygenation, depending upon the condition of the patient, and immediately start ACLS. If the condition, I mean, if there are more severe cardiovascular system, you may have to start ACLS. And whenever available, immediately start intralipid emulsion therapy. How does it work? It forms an expanded lipid compartment within the intravascular space, drawing local anesthetic from its receptor site. So it sort of dissolves it. This is called as lipid sink, that ILE takes up the lipophilic moieties and transfers them into a site of storage and detoxification, like skeletal muscle and liver. So there is sinking and shuttling. It enhances the fatty acid metabolism, and it has also direct cardiotonic effect. This is the regime in which we give initial intravenous bolus of 20% intralipid emulsion at 1.5 ml per kg over 1 minute. And immediately after that, start an IV infusion of 20% intralipid emulsion at 15 ml per kg per hour. Now this goes on for 5 minutes. So bolus 1.5 ml per kg over 1 minute, and then infusion at 15 ml per kg per hour. After 5 minutes, again you assess. If there is cardiovascular stability is not achieved, or there is positive deterioration of the circulation, you can give 2 more bolus doses and also continue infusion at the same rate or double the dose to 30 ml per kg per hour for 5 minutes if there is further worsening. Similarly, you can give total 3 bolus doses and followed by infusion. Do not exceed a cumulative dose of 12 ml per kg. Mind you, all this regime, it usually involves administering almost 500 to 600 ml of intralipid to the patient. So any place, any OT where you are giving regional anesthesia very frequently, your fridge should have at least 5 to 6 bottles of intralipid at any given time. So the take-home message would be patients receiving regional and local anesthesia should be monitored for last. Recognize the toxicity at the earliest. ABC of resuscitation followed by ILE. Third calamity, intraoperative accidental extubation under anesthesia. Most dreadful. So this is a patient, 35-year-old male, was undergoing excision of posterior fossa tumor in prone position. The patient's trachea was intubated using 7.5 flexometallic tube. The tube was secured and dead prone position was given. I mean, sometimes the prone position can be there with the neck turned on one side. So this was dead prone position. Air entry was equal. After 3 hours of surgery, the EtCO2 tracing disappeared suddenly. The low airway pressure and the apnea alarms were activated. Air entry on auscultation was absent. After crawling down the drapes, we found that the fastening tapes had come off due to secretions. So what next? What we can do? Of course, inform the surgeon, call for help, and attempt face mask ventilation. It is really difficult to ventilate these patients in dead prone position because if you know this position, the patient's head is fixed in the support, cervical spine support. Decided to make the patient supine. Asked for trolley, microscope had to be moved away. The surgical field had to be covered with sterile mops. Now all these things, all these steps, they take time. So meanwhile, an attempt at insertion of SJ was made. An IGL was inserted in prone position. I mean, attempted to put in prone position. The ventilation was inadequate as there was leak. Even EtCO2 did not show proper tracing, and therefore that means the SJ was not properly placed. Hence, that method was not appropriate. So patient was made supine on trolley meanwhile. Previous endotracheal tube was removed and the patient re-intubated. What can happen during this? There is delay in securing the airway because from prone to you have to make supine. There can be problem with sterility of the operative field, and it is especially dangerous in cervical spine fracture patients, because it can really make the fracture unstable. Now, this is a book, Clinical Airway Management, an illustrated case-based approach. The very first chapter is on accidental airway loss in prone position. There are multiple case reports of this. In fact, I remember when I was absolutely first year resident, the similarly tube had come out, but our then HOD, Dr. Deval, very miraculously he could reinsert, I mean, he could reposition the tube just by crawling under the drapes. Such was his greatness. So every time it may not be feasible. With the availability of the video laryngoscopes, one may attempt in reinsertion of the tube in the prone position. You can see it in the diagram, So here he has used AirTrack Avant. Best is prevention. So such things should not occur even to your worst enemy. So prevention is the key. Carefully securing the endotracheal tube with tape, and then also first you have to put throat pack. So it is flexometallic tube, if you know, it is quite wobbly. So you have to secure it in place by using throat pack and then carefully securing with elastoplast. Secure the Riles tube and temperature probe separately, not in the same sticking as the endotracheal tube, and there should not be any drag on the breathing circuit. If there is extubation in prone position, at one time you ask be prepared to turn the patient in supine. Meanwhile, you can mask ventilate with 100% oxygen with nasal or oral airway and attempt intubation in prone position using VLS. Still, all the paraphernalia is arranged. If you are successful, then complete the case with endotracheal tube. If it is unsuccessful, then anyway you have to turn the patient in supine position. Before doing so, you may attempt HGA insertion. There are many case reports where insertion of iGel was easier than any other videolaryngoscopy, any HGA. If ventilation is possible through that, continue to ventilate, and if there is if possible, if it is feasible, you can complete the case on HGA or ILMA or intubate with fiber optic bronchoscope through iGel. If, however, ventilation is inadequate, you have to turn the patient in supine position. So certain, again, take home message, always secure the tube properly, continuous monitoring of the airway pressure and EtCO2, because that will give you an immediate idea whether the tube has been malpositioned. And airway gadgets for emergency access to airway should be ready, including the stretcher or the trolley where you are going to turn the patient supine. Next calamity, anaphylaxis under anesthesia. 40-year-old patient, known case of hydrated cyst liver, was being operated by laparoscopic surgery. As a protocol, patient was given steroids at induction. Intraoperatively during dissection, as the cyst was punctured and it was being sucked, the airway pressures were found to be 58 millimeters of mercury. Immediately, the senior anesthesiologist started manual ventilation. It was stony hard. The bag was stony hard. There was hardly any air entry bilaterally. Same time, patient had severe hypotension. It was 50 by 30 millimeters of mercury and even lower. Heart rate, there was tachycardia. It was immediately treated with intravenous fluids and injection adrenaline, 100 mics in Aliquot. Hydrocot was repeated and injection Avil was given. The airway, slowly, the patient's blood pressure came up, airway pressure dropped, BP was normalized, and air entry could be heard. Another patient was, now this patient was not intubated. He was undergoing CT scan with contrast, and after injection of the dye, within 2 to 3 minutes, patient had severe erythema and urticaria all over the body. His breathing was distressed and had edema all over the body, which developed within a span of few minutes. The saturation dropped and there was severe hypotension. Severe laryngeal edema was suspected. Now, this patient was given Avil hydrocot. The sisters do continue to give, and adrenaline, but the respiratory distress continued. And here it was decided to intubate the patient early, because afterwards, once the full-fledged angioedema develops, it may be difficult to intubate the patient later on. Perioperative anaphylaxis to drug is very common. The major culprit are the antibiotic, that also amoxiclav and teicoplanin. Initially, it was penicillin. Then neuromuscular blocks, as blockading agent like DTC, rocuronium, atracurium, mivacurium, and succinylcholine. In addition, other drugs that are or substances that we use perioperatively, like chlorhexidine, especially when you put intravenous lines which are impregnated with chlorhexidine, one has to be careful. And certain other miscellaneous agents, gelatins, blood products. So immediately after starting blood or blood products, you have to be really careful in monitoring these patients for development of any untoward event. So it is severe life-threatening generalized or systemic hypersensitivity reaction. And the NAP6 study was on anaphylaxis, National Audit Project. It is during anesthesia presents differently than any other after oral ingestion or envenomation. So these are the different stages of or gradings of anaphylaxis. Not all patients have, those who have allergy will develop the full-fledged anaphylaxis. Some may have just cutaneous symptoms. So in them, there is no need to, you have to be just careful and watchful. But in grade 3 and 4, they are life-threatening anaphylactic reactions. And what are the signs and symptoms that you see? This is again from the NAP6 project. The majority of the symptoms was hypotension followed by bronchospasm and tachycardia. Our patient exactly had these symptoms. The rest of the manifestations also can occur and you have to be ready. So how are you going to treat these patients? Stop allergen. So whichever it is, anesthetic drugs, if you have started blood or blood products, stop that. If somebody is injecting dye, stop injecting dye, antibiotic, etc. Usually antibiotic we do give test dose. Consider lightening the area, anesthesia, because at this time the patient, you cannot ventilate the patient and the patient has severe hypotension. So the further deepening the anesthesia is going to make the matter worse. Leg raising for sudden increase in the central blood volume, give 100% oxygen, secure the airway early. If not, if the patient is having respiratory distress, liberal intravenous fluids. The initial line would be crystalloids 20 to 30 ml per kg. If required, colloid only as a second line, because colloids, few of the colloids also can cause allergic reactions. Injection adrenaline, IV fluids and injection adrenaline is the mainstay of treatment of anaphylaxis. So 50 to 100 micrograms intravenously followed by infusion of 0.05 to 0.1 microgram per kg per minute you can give. I mean, you can repeat till the symptoms abate. NAP6 has suggested CPR to be started if systolic blood pressure is less than 50 millimeters of mercury without cardiac arrest. I mean, at this time, it is usually the PEA. So the treatment again would be CPR along with adrenaline, 1 milligram every 3 to 5 minutes, because then you treat it as CPR. And lastly, the other disaster is subarachnoid injection of a wrong drug. Very unfortunate event. A 24-year female patient was taken up for emergency LSCS. Patient was not hypertensive. 2 cc of spinal drug was injected into the subarachnoid space. Immediately after the injection of the drug, the patient was made supine and she had excruciating pain in buttock, back and going along the legs. As soon as she laid down, she started having severe jerks, which were mistaken for convulsions due to eclampsia. Hurriedly, general anesthesia was given because baby had to be delivered. The surgery underwent smoothly. At the end, the patient was reversed and again she started having severe myoclonic jerks. That time it was felt that something different has occurred. Meanwhile, the ampule that was used for her was retrieved from the box. Look at these ampules. One is bupivacaine and one is tranexamic acid. So a wrong drug was injected in the subarachnoid space. Neurophysicians were involved, EEG was done. The patient continued to receive injection midazolam high doses along with other anticonvulsants, and she was put on ventilator. After 4 days, the patient recovered and subsequently discharged by the grace of God. Now, there are multiple reports of this mishap with 50% mortality. I mean, from this article, which was published in 2021, that person has said that total 21 patients were reported. Mind you, and this must be just tip of an iceberg. Not many of the mishaps are actually reported. So we are probably dealing with a higher number of such cases with 50% mortality, which is quite great. So these are the patients which suffer from tachycardia, hypertension, polymyoclonus and severe pain. With lower extremities was the commonest manifestations in all these. Few patients developed ventricular fibrillation. Now the treatment is symptomatic and supportive. Multiple anticonvulsants, induction of anesthesia, treatment of hypertension, tachycardia. In few of the case reports, they have given CSF lavage using epidural catheter. Injecting normal saline and then aspirating some amount of CSF. So as to reduce the concentration of drug in CSF. So what are the problems? Wrong labeling, incorrect location. The sister had kept the wrong ampule in a wrong box. Human errors such as inattention, fatigue, poor communication, lack of systematic medication guidelines. I mean, there are no universal guidelines, at least in our whatever in our institute, in our country, we fail to learn from others' mistakes. After reading case reports, we have to realize that sometimes all these things can happen to us, and that is very important. So what is required is constant vigilance, clear labeling, formation of protocols such as 2-point identification. Every ampule, whenever somebody breaks, he announces and it is checked and confirmed by the other. Proper storage and preserving the used ampules which are used for that case. At the end, if something happens, you can go back to box and see whether you have given wrong drug or no. These are the guidelines which were published by AAGBI, catastrophes in anesthesia practice, and how to deal with an aftermath. There is meticulous record of the event is must. Briefing the relatives. You have to tell them, take them in confidence and tell them, or breaking the bad news. If the mishap has resulted in death, continuous follow-up, psychological support not only of the relative but also of the anesthesiologist involved. These mistakes can be by anesthesia residents, and if they get such a negative feedback during their formative years, then it can ruin their career. Debriefing of the episode in the department. You have to discuss such events in the departmental meeting, so lessons are learned, not for accusing people. So how to prevent catastrophe? Now it is really difficult. You cannot have double-blind cities or observational studies of such events because they are very rare, and it is unethical to produce so. So what you have in hand is using simulators. Even case series is difficult to formulate. I mean, these events can occur only once in your lifetime of anesthesia career. We have to rely on case reports and learn from others' experiences. Simulation is the way ahead. Formation of protocol and adhering to them. And reporting of events. I mean, we have to be bold enough to report such events. And prevention is always better than cure. Thank you, all of you. Thank you for the patient listening.
Thank you, ma'am. Before we take up the question answers, let me thank you. Thank you, ma'am, for a very nice talk in a very practical and concise way. It was a really nice explanation regarding all the catastrophes. I'll just check the chat box for if there is any question answers. Ma'am, there's one question regarding the first case. Why was pentothal used instead of propofol?
Now we don't know in which place this has occurred. Yeah, it depends on who is anesthetizing. I mean, it is not done in a place where it was done. These are the isolated case reports which I have picked up. It depends on the availability of the drug, whether it was done in in the peripheral areas where propofol may not be available, or the anesthesiologist must not be using propofol. So many factors come in, or that person hasn't paid attention to all this, that if the patient is a known smoker and if he has had a URTI just 4 to 5 days back, then probably pentothal is not the drug to be used. I mean, last so many years I have not touched pentothal also. So many factors are there in this.
Ma'am, there's one question: how to deal with grade 3 to 4 anaphylaxis if not responding to adrenaline and fluid, taking time for blood pressure to increase even after use of noradrenaline? Yeah. I think maybe they want to ask how to deal with grade 3 to 4 anaphylaxis not responding to adrenaline or fluid. Yeah, adrenaline. So usually if it is not responding to adrenaline, alternate drugs are there. Like noradrenaline you already mentioned. Then one can use vasopressin also. And there is a mention of injection glucagon also. So all these drugs can be used. And if required, then you can use, to stabilize the circulation, one can use ECMO till the action wears off. Okay. There was one suggestion from Dr. Manisha Ghosh that it is better to use preservative to local anesthetist. And Dr. Mutha sir has said ki is nasal endotracheal tube better than oral for prone position?
Yeah. Definitely it can be better because it remains, the stability is more with nasal endotracheal tubes.
Okay. And Dr. Poonam has recommended that glucagon is better if patient is on beta blockers.
Yeah.
Okay. I think that's all for the question answers, madam. Thank you once again for a nice talk and sparing your time and coming for this webinar. Thank you, madam.
Thank
Dr.
you. Thank you.
Vaishali,
Yes.
you can just start with the next speakers.
Yes. Yes. Varsha, can you put up the slide for Shetty sir? Varsha?
Yes, ma'am.
Okay. Dr. Shetty sir, you are there?
Varsha, you have put the wrong slide. You have put the slide for Dr. Sir.
Yes, ma'am. I'm here.
Varsha, please put the slide for Shetty sir.
Yes, ma'am.
Yeah, okay. Yeah, that's it.
Thank you. Yes, it's visible. Thank you, Varsha. I'm feeling privileged to introduce you all to Vijay Shetty sir, who is actually a well-known person. He is head of anesthesia department in Fortis Hospital, Mulund, Mumbai. He has done multiple publications. He was a secretary of Mumbai Anesthesiologist Society. Shetty sir is executive member of Indian College of Cardiac Anesthesia, but he is well known for he keeps on organizing the popular meetings, the Massacon. He was a part of team which conducted the first successful heart transplant, and he has given anesthesia to the 100+ cardiac transplant patients. So we are very eager to hear you from Vijay Shetty sir. Over to you, sir.
Thank you very much, madam. Can I share my screen?
Yes, sir. Varsha, can you help to share the screen?
Yes.
झूम अपडेट करायला लागतं नाही ते पण प्रॉब्लेम होता आधी
Other members to keep your phone.
Sir, please unmute yourself.
Yeah, I got it. Let me just try again.
Just click share button.
ये है Zoom. ये है share.
Sir, open the slide and then start sharing the screen.
Hello.
Shetty sir, you are there?
There, madam. Sorry, my computer gave problems. I'm sharing. I am using Mayuri's laptop.
Okay, sir.
Play with this. So just give me 1 minute. Otherwise, if Sandeep sir is there, I can ask. We can request him to go ahead. Is that okay? If Dr. Mutha is there, just try. Okay, I think I got it. Hold on.
Good.
Okay. Okay. Yes, we can see
my slide.
Yes, sir.
Okay, Dr. Sandeep, you can relax. So this is my talk, actually, Adventures, Anesthesia and Laparoscopy and Gynec Endoscopy. I want to give sincere thanks to, I've been invited by Dr. Maya Balirao and Dr. Kavita Madam. I have fond memories of working in Sion under Dr. Kavita and Dr. Satish sir, because they taught me some of the things that you're going to hear today. So I think it is all coming back Kavita madam, if you make any errors, it is because of you, I'd say. And sincere thanks to Dr. Varsha for keeping a tab on these proceedings. I want to say that I bring greetings from Fortis Hospital, Mulund. I have no industry partnerships, at least not for this talk. And sometimes when you speak about some subject, people assume that you're an expert on that. So if I'm speaking about complications, I just want to say that I'm not an expert in creating complications. It's just that because I'm interested in seeing what happens in other OTs. When I was doing only cardiac, and now as a head, I get to see supervise 7 to 10 OTs at a time. So obviously, I'm really keen in seeing that I prevent the issues that are cropping up from time to time. Today, we see laparoscopy, endoscopy in all these different care areas. I won't go to that. One of the first things that came when at least it came up to the cardiac surgery was that the legendary surgeon Denton Cooley mentioned that we have successfully made cardiac surgery more painful for the surgeon than for the patient. That is how it was looked upon at once upon a time. But today, and I know that even in small towns and cities and remote places also, endoscopy and laparoscopy keeps coming up because we have standardized the way that it is done. It is because of the team approach. And there are now minimal complications, rapid recovery, and ERAS protocols now encourage us to get into more and more into these endoscopy minimal surgery, minimally access and endoscopic surgeries. But what happens, like when we're working at Fan Hospital, one of the important things that the senior would see when you step into the OT of a junior was that whether the junior has got a hand on pulse. Now we can see that in modern anesthesia, ventilation, positioning, proximity, all these are compromised because of the horrendous things that we subject the patient to. Only because the patient is under anesthesia, they are able to bear all this. But your proximity or the touch or the feel that you have for the patient is definitely not there. And what our surgeons and our teams are trying to do, or the industry is trying to do, is that they're trying to make things more and more difficult. It might take a little longer, but even impossible things are tried now. One of the things that must be bothering all of you in your practice is Trendelenburg position. And you have to remember the simple thing that more the tilt, more the issues as far as ventilation perfusion mismatch is concerned, raised ICP is concerned, raised IOP is concerned, and passive regurgitation. Sometimes you have patients under the drapes. When you, at the end of surgery, you realize that the patient are just, the Trendelenburg was so steep that they bought off a lot of secretions, and just because maybe it was a head low, they don't aspirate, or because of big good cuff position. But we need to be aware that any patient who's got any of these like pre-existing issues is at risk. For example, a patient with a raised intracranial pressure will end up with complications if we give Trendelenburg for more. Now, this is just a simple repositioning checklist that whenever you position a patient, I just want, I hope some juniors are there here. Like just like we do the ABC, we just need to be sure that your airway, your breathing and circulation, and I just try to tell you what are the things that you would want to see. Make sure that every monitor that we are monitoring is available, and don't compromise anything. If your value in the monitor is abnormal, don't believe that's a monitor problem. It may very well be a patient problem. Disability check. This I want to highlight because often on and off, you'll be hearing of some colleague, or maybe you also have this problems where the patient was blind after the surgery, or he had a neurovascular injury at the surgery. So these are things in a hurry we forget. Like we do the same lap chole every day, but one day the lap chole might last for 2.5, 3 hours, and we have just pulled the arm down by the side of the patient too firmly, and it's been tucked in. And because the surgery was such a prolonged nature, you would end up with a problem. Even short duration surgeries in which there have been severe ischemic episodes can also lead to neurovascular problems or ocular problems or vision problems. So never underestimate the risk that you're running. Just because you had 15, 20 years of good anesthesia and no complications, it just requires one case. So it is just, again, the statement is for the juniors. I think all of us have learned the hard way, but that you can never, ever leave the patient alone. Because in your absence, some things will happen which you don't notice. And one of the first things that happens when you have a problem on the monitor is you get upset or you get worried. You will get worried only if you are not watching the monitor. You get what I'm saying? If you're looking at the monitor at all times, you see the progress, you see the fall in the saturation, or the rise in the EtCO2, or a fall in the EtCO2, or the sudden rise in temperature. Those things you'll be seeing because you're watching them. It is only when you're not paying attention that you start getting worried. So if you've been watching the patient, watching the monitor, you don't have no reason to get worried because you will have a solution for the problem, is what I would want to highlight here. Also, make sure that all cables, electrodes, sometimes they leave a very big rash on the gash on the patient and injuries on the patient. And in our corporate structure, actually, it is very difficult because it's not only annoying for the patient but also for you, because you have to fill a lot of paperwork for explaining why injury happened to a patient. So even all the more reason why we should have. I want to talk about a simple thing called the tracheal leg. Now this every few months I get into a situation where I am correcting these issues with in across, and I want to just talk about this tracheal accordion and the position of the ET tube. Now this is the lengthenable or the elongating or the shortening position or the part of the trachea. Now we can see here whenever the patient assumes a supine position, or there is a diaphragm is paralyzed, or there is a paralysis of the head and the neck extension, this is pendant position and pneumopolit. These are the sequences of events which happen in any normal laparoscopic surgery. And you can see this is the average change in the distance of the ET tip and the carina. You can see 0.6 to 1.5 centimeter, all the way down to 0.9 to 1.3. So if all these things were happening in the patient, it will be no surprise if a tube which is lodged here very well goes into one side. And this will lead to a lot of problems. So that the tube can, a perfectly placed tube can migrate, especially in a patient who is vulnerable to this, should be noted. So your tube should not be too high or too low, irrespective of how many years of experience you had. Now this patient, for example, is a short neck and a very obese patient. You could have this patient where the VL laryngoscope is showing that a patient's scope, a tube is not well positioned and the cuff is actually herniating out of the vocal cord. Or it could be very well that the patient whose tube was positioned here, because of all the things that you mentioned in the previous slides, the tube was migrated to one side. One of the things that I am very fond of talking is one is 2D echo by the anesthetist, and second is the bronchoscopy skills. So all OT should have a bronchoscopy. So you can very well confirm not only the position of an endotracheal tube, but also the position of a sort of when you are struggling with the LMA positioning also. You can very well see that your LMA or the endotracheal tube is well positioned in a matter of just 5 seconds. But if you have a available bronchoscope, so even this is one thing that we need to talk about, because we have to make our life comfortable. There is no point in spending a life avoiding complications. Like I always tell my juniors that you are just your complication is always coming towards you and you have to keep escaping it. But we don't have to live a life like that. We can make our life more safer, and we have our own scopes, not only the surgeons. So lesson to be learned is that take time to position, especially in obese patients and sicker, fragile patients. If you go back to your problems, you realize that most of the patients had something pre-existing. Either they were obese or they were fragile. They had some anticipated airway problems. And you can very well tell your surgeon who is in a hurry to get things going that a lot of surgical distress and discomfort will happen if you don't let me be comfortable the way I'm doing things. It doesn't mean that you spend inadvertently long amount of time, but then that you have to have enough to see that you are efficiently positioning. And it is here that you require a good help from all your OT and teamwork. So make sure that you all work as a team to see that your patient positioned well. I'm not going to this. Everybody knows about the lung compliance and what it does. And even very decently priced monitors have this compliance being shown as a graph. So I would request that if you go back to your practice and you're not following it, just keep seeing what happens to the compliance, and you also get an idea about how to manage this. The other thing I want to talk about is a protective lung ventilation. Now, the effects of non-protective lung ventilation it may not affect you directly, but there are hordes of patients that we do, and we subject them to very high tidal volume, very high peak pressure, high driving pressure, and they will go out of your OT. But then you have subjected their lung to a lot of injury of mechanical and pressure types. And that is why it is recommended that you have a tidal volume of around 6 to 7 ml per kg, a PEEP of less than, PEEP of around 5. Have a good respiratory ratio. Use an FiO2 which will give a saturation about 90 to 94. You don't require 100% saturation. This I'm talking about patients who are at on the border. So you have something backup. If you give 100% oxygen in the beginning, you have nothing to give if there was hypoxia. But if you are giving us a 60 to 70% in a patient who is sick and fragile, to get a saturation of 93, 94, you would probably be doing a better job than getting a saturation of 96, 97 with 100% oxygen. Always see what happens to your tidal volume and your peak pressure, depending on which mode of ventilation that you are using. Now, if these maneuvers are unsuccessful, your patient might be in immediate danger of hypoxemia. There is risk of increased CO2. This leads to BP, heart rate oozing, and it leads to pharmacological misadventure. That means if I get hypertension and tachycardia, or if I get hypertension with a normal heart rate, then I'll try to do start an NTG or an NTG or a glyceride or beta blocker. Now, these are misadventures which could be prevented just by doing proper, standard, careful anesthesia. Okay, and also it will lead to delayed awakening. So the interventions are that you can use a VIL scope. So this is another instrument that we should all be having in a routine because it makes our life very easy. So use of video laryngoscopy after final positioning. You can do bronchoscopy positioning or confirmation in difficult cases. Multiple causes of light anesthesia. Every few weeks or months we'll have this anti-vaporizers, poor quality drugs. Suddenly a new drug comes which is not working at all. Those have a proper pressure control, ventilation adjustments, and you watch the surgeon as to what is happening. Now this is the feet and this is the head of the patient, and this is you can see in a robotic prostate or in some certain surgeries that are significant head load. So this patient might very well slide off the table if it were not for so many restraints which are holding the core of the patient. This again I'm going to skip the CO2 insufflation. You have to understand it is an abnormal thing. We see CO2 insufflation every day and we assume it is a part of our system because CO2 is there in our blood anyways. But look at the abnormalities, including tissue desiccation and immune suppression that are happening to this patient. It gives you an abnormal stress response. And now our surgeons are doing more and more prolonged surgeries on the, especially onco surgeries, robotic surgeries. They've gone for a huge amount of time, number of hours. And you can imagine somebody who just builds up stress after stress after stress. At one particular time, the body might just give way. So just be careful about that. And EtCO2 is a very important problem. I'm sure important monitor. I'm sure all of us are monitoring EtCO2 in our, irrespective whether we are doing a laparoscopy or non-laparoscopy. It is especially important to see that rapid rise and rapid fall. Both are very, very dangerous. This slide, I'm just trying to show you that irrespective of surgery, you're doing a gynec surgery or op surgery, because anything can embolize to the heart. Anything that goes to the blood vessel can go to the heart. Look at the number of things that are there: fat, amniotic fluid, tumor, gestational or topoplastic cells, septic emboli in infected limb, maybe hydrated cyst. So these are all things that are hurtling towards the heart, and this can lead to sudden drop in the CO2. So what are the challenges for the anesthetist is that how to maintain normocapnia, avoid hypoxia without having too high airway pressures. So we watch the EtCO2 as insufflation begins. The EtCO2 will rise. You need to adjust, increase the minute ventilation, and the compliance of the lungs will also be affected. So once we start looking at numbers, so I am always been a number person. I always see that we can watch what is happening as long as you have some tangible targets or some reasonably good targets to look at, and always imagine ventilation, ineffective ventilation, shunts or ineffective alveolar ventilation happening in these patients. And once you get a concept about what might be happening in some zone of the lung, you will institute therapies to take care of them. And this is for the surgeons actually. They need to be asking the anesthetist, are you okay? So there have been cases of inadvertent vasopressin injection. I know that all of you would be seeing that as well. Because of a huge fibroid or such, the surgeon tends to inject. And originally they were injecting very concentrated doses of the vasopressin into the fibroids, and obviously they're very vascular structures. You will have the situation where you are just looking at the monitor. Suddenly there is severe bradycardia. There is no pulse on the hand because all the vessels are constricted. At that point, look at the CO2. Okay, you wait for the effect of the vasopressin to pass out. Because what the first tendency would be to give atropine, to give adrenaline. Actually, you have given even a more superlative vasoconstrictor. There is no point giving anything else to correct that. And with time, it will pass away, obviously. But look at the EtCO2. If EtCO2 is maintained, you're in a zone where the patient is going to be coming up. This was again a question for the juniors. This is pneumothorax. A spontaneous urothorax. This happened in the case of laparoscopic cholecystectomy. I'm sure that many of our patients get this complication on and off, but they are not severe enough to give a problem. But this is one thing that you need to be aware of. When you're pushing air into one or CO2 into one cavity, there is no reason why it won't go to another one. This is again a surgical emphysema you will see. And this is what I was talking about, the number of naturally occurring foramina bronchial leg and foramina magnani, which are existing on the diaphragm as it separates the chest from the abdomen. Whenever you put air or CO2 onto the abdomen, it may find its way through this and many more abnormal openings into the chest. And you can imagine what will happen if the patient is already a fragile lung person. This is a case report of a delayed pneumothorax in which the patient had first a surgical emphysema and then Subsequently, because of the dissection into the pleura, he developed a delayed pneumothorax. So what can go wrong? And this is just a friendly advice. When the anesthetist decides to treat everything by herself or himself, the surgeon decides that the anesthetist surgeon decides that I am only going to do surgery, and the anesthetist is primarily responsible for the patient's well-being. And communication between the two parties begin after a problem is at the peak. So we have to be more communicative. I mean, even if you don't like the surgeon, make sure that your professional and the emotional relationship are very different. And professionally, you are at the same place, in the same plane, and you are able to communicate. This was one case that I would like to again point out in the difficult airway, but this was again a loss of situational awareness, which all the situations that Amla madam mentioned in the previous presentation. If the anesthetist there has a loss of situational awareness, meaning there is no focus on the time that is spent while managing a complication, and repeated attempts are, we keep doing the same attempts. So if you do the same things, probably you end up getting the same results, is what Einstein said. And therefore, this tunnel vision means there is no sense of time. See, we are in corporate hospitals very fortunate to have this support of a lot of other seniors and able people at most times, except maybe in the middle of the night. But that has to be in some way also be present in anywhere where you're working. You need to have people who are going to be able to offer the support. We all believe that increased technology, you will very proudly say, I got a ETCL today, I got a near infrared spectroscopy, I got a BIS. Increased technology certainly doesn't mean that you're increasingly, your situational awareness is improved. In fact, it is worse. As you can see in this picture, everybody is going towards a disaster in spite of having so many technologies at their hands. So there are a couple of reports where people have managed. This is a laparoscopic atherectomy. This is from China. I think only there it can happen. Can happen. The episode fell from 40 to 15 while doing the laparoscopic atherectomy, and he spent an hour in repairing that, even through placing a gauze and repairing the tear. And they had presented this. As far as treatment of venous embolism is concerned, I think we've already most of us know this part. The first thing is to inform the surgeon and see if you can plug further aspiration of the air. A paradoxical air embolism in any patient with a AST or a PFO, be very wary that most often these shunts have bidirectional flow, meaning though the blood is mostly flowing from the left to the right, in most cases until Einstein migration happens, there is always a bidirectional flow, meaning anything that you push into the right side will find its way into the left side. And most often we do not know which patient has a PFO or an AST. So it's a good practice to make sure that all your IV lines are without air, irrespective of whatever the patient is. If you make it a culture in your practice, or your technician or your boy or your nurse or your junior, he's going to take care of that, and you're very strict about this. Then even if you are able to prevent air going to the right side, the paradoxical embolism is dangerous because normally the air goes into the pulmonary artery and gets stuck there. If it's not of a great quantity, it will not do any harm. But even a small amount of air which goes from the right side to the left side, it can go to anywhere, right from the heart to the coronary arteries, or it can go to the brain, kidney, anywhere. So, and these can be disastrous complications. You can imagine that you could think about this part as well. And this is an interesting study which showed the carbon dioxide embolism to laparoscopy surgeries. They're just doing laparoscopy surgeries, and they had various other techniques to see. And one of the important techniques that he used was a transesophageal echocardiography, and they found that 40 out of 40, that means 100% of the patients had air detected in the RA and the RV, meaning your air embolism is always happening. It is only the quantity or the less quantity that is going to save your patient. And if it were to be a significant quantity, or if a patient was sort of suitable to get an important problem, then even a moderate amount of air would be dangerous to you. So imagine that you'll always be knowing that air is always coming towards your heart, and at all times, 100% of the times. Now, severe hypothermia in extended lap, this is another thing that we need to be aware of. I hope that all of us are monitoring our temperatures. I sometimes visit where my wife works, and I know that the OTs in the private practice are usually not as cold as there in the corporate hospital. But you can very well say that if the patient is well exposed, the surgery is long, if warm fluids are not being used, if the warming techniques are not adequate, or the patient is frail, the temperature can go down below 30, 32 degrees. And in this, you get a lot of problems, including coagulation, including arrhythmias, delayed awakening, pharmacotherapy, and so on and so forth. So we need to have this. Also, it is now that there is a term, there is a thought whether we should, even the CO2 that we insufflating should be warm and humidified. The lesson here is that first we have to learn to monitor temperature and also have active warming protocols. Now, these warming protocols work best only when you have instituted them before the hypothermia has occurred. If you find a patient is already 32, it is very, very difficult to warm them back again to 35, 36. Whereas if you started the warming, even when the patient's at the beginning of the surgery or the induction of anesthesia even, you would have seen that the patient's pressure would never drop below 35. This is a very important lesson. So you monitor adequately. Invasive monitoring, again, one more point I would like to make, and I am very fond of saying that have a very low threshold for using invasive monitoring to make your life easy. And this is for all these difficult patients, long surgeries, make sure that you have arterial line, which will give you a world of information to monitor. I want to talk about this one case where there is a 25-year-old for salpingectomy. I think it was a 35, 45-minute case only. And she developed bilateral compartment syndrome. So you are shocked because a day in, day out, you're doing these cases under in the lithotomy position, and our patients are pretty well doing well. So you can see she had a very high creatinine kinase. On neurovascular examination, that was okay. There was no DVT. She complained of severe bilateral calf pain. Now, this is one symptom you never neglect in any patient post-operative, whether it is lithotomy or otherwise, because the patient could very well be having acute compartment syndrome. So never neglect bilateral or even unilateral calf pain. And she went for compartment fasciotomy. She did well. So this well compartment syndrome is something that I wanted to highlight, where after a lithotomy position and these risk factors, including intraoperative hypotension, hypovolemia. So these are very common things in our practice in major surgeries. Peripheral vascular disease, you don't actually see or evaluate a patient to see, but anybody with diabetic hypertension, you can assume that they have significant peripheral vascular disease. Prolonged operation, normally we like to see people who have muscular calf, we think they're very healthy, but these very muscular calves are going to be a high risk factor for getting the well compartment syndrome, and a very obese patient, a high body mass index. So what happens is that there is a local arterial pressure decrease of almost 0.75 millimeter for each centimeter compartment that is elevated above the right atrium. So it is also thought that stockings and pneumatic compression may not be helping for this. It might be detrimental, and it has a higher tendency that is appreciated. So if it's not diagnosed and treated early, it can have disastrous consequences, including amputation. So please never neglect a patient who's got a calf pain complaint. This, I think anybody doing enough urology work would be knowing this, that there's a gradient of 30, which is that can be massive absorption. So we be careful about whenever this. So this is the post-TURP syndrome. You can see patient has got acidosis and lung overload and desaturation as well. So I want to talk about this Ohio syndrome, which is the this happens. This is because the gynecologists were being left out because the TURP syndrome, it made it term like a urology syndrome, and even their complication not getting a name. So they decided to having operative histoscopic intravascular absorption syndrome. The Ohio syndrome is nothing but the same TURP syndrome occurring in a female patient. And you can see we use glycine or normal saline, whatever we use. The patient can end up with a fluid overload. It can end up with hyponatremia, depending on what we use. So the standard treatment that we do for a TURP syndrome needs to be done, including monitoring of fluid status and a parotid area sign. Parotid sign is again one sign where a fluid overload could be diagnosed. Similarly, we have signs for the optic nerve diameter as well. One thing I want to tell is that many of us are doing the cases with LMA, and in the middle of the surgery, we find that the LMA, there is a difficulty in ventilation. Please be wary that, especially if something like a histoscope is going on, or something where there's also irrigation going on, it could very well be a case of a massive absorption of these fluids, because that is when the lung compliance change. And this is actually very well too much in the game, too much ahead in the game that we not picked it up. And these patients have to be immediately intubated. And rather, we would like to adjust that LMAs, but in this case, it would be better to intubate the patient and then work them up. This patient had a very low sodium, and this is what happened to one of my patients as well. So this is, I think, just a case scenario I can talk about a lap pelvic surgery. It was around in the evening, a thin lady, no comorbidities, excellent experienced surgeon, a very good friend of mine. We had put a central line for post-operative indication. And this is one of my alert anesthetists who picked this up. You can see that there is no arterial line in the beginning, and the ETCO2 is 24, 20. This is minute to minute reading, 12 seconds reading, and just like that, it fell from 24 to 17, and then 13. Okay, and this in this, you can see within 1 minute, it has come from 20 to 14 and 12. This is a 1 minute reading. This is 12 seconds, this is a 1 minute reading. And immediately and this was the point when he was putting the trocar inside, immediately the patient's BP fell, the ETCO2 fell. So you can imagine this happening in your practice, like every day you work the same surgeon, you are gossiping about the last movie you saw, and you put in the trocar in, and suddenly the ETCO2 goes blast. So you need to have a lot of people to come in and help. For example, here we put in the RTL line, we resuscitated, and immediately the abdomen was opened, the pressure was applied at the bleeding point, supports were started. You can see the HB has fallen down to 3.1 and then to 2. And ventilation and BP became better. And on opening, you found that there is a rent in the aorta. So where the aorta divides, there is a rent there, and the vascular surgeon quickly repaired it up. The further surgery went on uneventfully. Obviously, instead of having a lap surgery, she ended up with an open surgery and also put her feet or the limbs at risk. And then when the clamps were opened or the recirculation of the limbs were coming in, you could probably here appreciate a rise in the ETCO2 also. I don't think we'll wait for that. So ultimately the pupils are good. 8 blood, 600 ml FFP, 2 SDPs were given. HB came up to 9.5. ABG was good. So what I want to say is that never give up on a patient who has come into your OT in a good shape. And it is by a good amount of teamwork and having protocols to manage and having resources to manage that you can do this. But irrespective, I've seen that my friends have managed such patients even in their private practice just by being diligent, by being ruthless about not giving up and getting help where it mattered, and having a lot of people around who were trained to, or at least been able to give them, offering them help. So this patient was awake and pain-free and extubated after 8 hours of. So one more thing that I'm not an instrument guy, but I like to see that we have enough equipment around us, which I'm going to say. So one of the things that we use for such case is point of care coagulation correction. This is a simple test called sonoclot. We have the rotem as well, but the sonoclot is very cheap and it's quick, and within 1 or 2 minutes it will give you what is happening. This is the initial trace. You can see the platelet function not good, and this after the correction, you can see that this has been restored. And I just like to end with saying this fixation error when you're saying laparoscopic surgery or when you're seeing robotic surgery going on, you're fascinated with what is going on the screen. A good anesthetist knows that it is not his job to appreciate what has been happening there. Of course, you have to watch, but our primary contract with the patient is to keep the patient safe and prevent the complications so that we have less and less of these kind of talks. Thank you very much once again, Dr. Kavita Madam and Dr. Maya. I hope that this was a useful presentation for you. Thank you so much.
Thank you so much for your wonderful lecture, sir. Actually, well said. I like the heading of your lecture. That is adventures. These are really adventures which makes your adrenaline really rushing. And the best thing you have said is never give up. That is best take home message from your lecture. Now we will have a look to chat box if there are any questions. I think you have covered all the questions, sir. One question was regarding the the rupture of major vessels, which you have covered. One new message. Yes, all the questions have been covered very nicely, sir. So thank you once again for your wonderful presentations.
Thank you.
Now I hand over to Dr. Seema for the next presentation. Dr. Seema.
Thank you, Dr. Vaishali. Yeah. Okay, so now we move on to our last lecture by Dr. Sandeep Mutha, sir. Let me, Varsha, yeah. Thank you, Varsha. Dr. Mutha, sir, is director at Pune Anesthesia and Criticare Private Limited and Medipar. Sir has been past IACTA Maharashtra President, ISA Pune Secretary, and Organizing Secretary of IACTA and Aura conferences. Sir has numerous publications to his credit. He has also conducted live workshops on regional anesthesia, bariatric anesthesia, as well as critical care. Sir is also a concept designer of Pran Niti, which he will be talking after his talk. Over to you, sir.
Thank you. Thank you, Seema. I would like to thank the organizing team for giving me the opportunity to talk on a subject which is very dear to me. Just let me share it. Yeah. You can see my screen?
Yes, sir, we are able to see your screen. Yeah.
Yeah, good. Okay, I would like to thank the PCMC and Solapur ISA for arranging such a nice meeting and on such a topic which is very dear to everybody, because we are coming across complications and problems intraoperatively and perioperatively many times. And most of the time we can deal with it, but sometimes it creates a big headache. So most of the problems in life are because of two reasons. Either we act without thinking, or we keep on thinking without acting. So if you do any of these, you can land in trouble. So coming to the cardiac part, there are multiple complications which can occur in perioperative period. It can be hypotension, myocardial ischemia, cardiac arrest, cardiac failure, arrhythmias, and so on and so forth. And you always worry now what to do, how to tackle these problems, how to keep the patient safe and tide over the crisis. This is a very common scenario which occurs. One second. Okay. This video is not playing just now, so I'll just, okay, it's playing. You can see that it's a normal sinus rhythm. I induce the patient, and what happens now? Suddenly we start getting some supraventricular ectopics. Now, this is a young patient not having any problem. Why is the myocardium irritable? If you come to this paper, it's on perioperative major adverse cardiovascular and cerebrovascular events associated with non-cardiac surgery. This study was a very large study of more than 1 lakh of patients, where they found that these problems occur in almost 3% of the patients who undergo a non-cardiac surgery. They concluded that the cardiovascular complications after non-cardiac surgery remain a major source of morbidity and mortality, despite the improvement in the perioperative outcomes over the past decade. So how it happens? If you see from 2004 to 2013, the complications remain the same. The death rate came down, but the cardiac arrest or myocardial infarction and the stroke were steady throughout the period from 2004 to 2013. That means our management of these problems have improved, that decreased the death rate, but still the problem remains. Most of these cases were either vascular, thoracic, transplant, neurosurgery, general surgery, and burns. These are the patients which give the maximum amount of cardiovascular and the cerebrovascular accidents. In one of these papers where perioperative cardiac management under general anesthesia, it suggested that general anesthesia can give rise to arterial and central venous pressure changes, the changes in the cardiac output, which can be very well monitored without doing a cardiac output monitoring with only EtCO2. If your ventilation is steady, you have not changed the ventilation, then decrease in the EtCO2 level can be an indicator that your cardiac output is decreasing, early indicator. And the heart rhythms. This can happen because of the changes in the systemic vascular resistance, myocardial contractility, the change in the stroke volume, and the myocardial irritability because of the drugs which we are using. Same with regional anesthesia. If you take spinal or epidural anesthesia, it causes sympathetic blockade, arterial and venodilatation, leading to hemodynamic changes. According to the same paper, it said that regional anesthesia and general anesthesia, there is no significant difference in the cardiopulmonary complications or mortality. In this landmark study by Martin J. London on hemodynamic management during anesthesia, he suggested that intraoperative management of blood pressure and heart rate are interrelated, and we have to maintain the parameters within 20% of the patient baseline. In hypertensive patient, it can be a little bit more, and in ischemic patients or ischemic heart disease patients, the heart rate should be maintained between 50 to 80 beats per minute, because otherwise, if it is these patients get tachycardia, there is increase in the oxygen demand and can lead to more ischemia. As we all know, heart is a very complex organ, and the problems can occur anywhere in the flow, in the neurovascular bundle. There can be decrease in the coronary perfusion, and so on and so forth. Our first case is a 33-year-old male for laparotomy who was diagnosed hypertensive on telmisartan, but he was taking intermittently telmisartan. In preoperative examination, his blood pressure was near normal, heart rate was fine, the investigations were normal, general anesthesia was given because patient refused epidural at this time. On intubation and skin incision, we got a pressure response where the blood pressure went up to 190 by 116, and it was not coming down with the depth of anesthesia. The heart rate had gone to 132 and required labetalol and the NTG infusion. Post-operatively, we had to continue NTG infusion for 48 hours. And on day one, we did a tropi and it was raised, but there were no ECG changes. So 50% of the patients are not aware that they are hypertensive or they are on irregular treatment. This irregular treatment or poorly controlled hypertension can lead to ischemia, left ventricular dysfunction, arrhythmia, and stroke. The incompletely controlled hypertension with diabetes can lead to autonomic disturbance and cause a labile blood pressure. Then it becomes a bigger problem. In preoperative visit, if you see that the systolic blood pressure is more than 180 and diastolic is more than 110, we have to control it preoperatively if it is elective surgery. Don't try to push the surgery because this can lead to a lot of problems in the perioperative period. If you see this, we have got a patient where the ECG was normal. Suddenly the patient started getting, the P wave was gone. And after some time, the P wave comes back by itself. This is a very common scenario which can occur. You can see that the P wave is coming back. So this is a very common scenario, and this can lead to a lot of misbeats for the anesthetist and the OT doctors who are there. Our next case is a 65-year-old male who was 76 kg for fracture neck femur, which was 5 days old. There was no significant clinical history. The preoperative ECG had a sinus rhythm, heart rate was, RR interval was 72. Regular spinal anesthesia was given with 3.5 cc of bupivacaine and 90 microgram of buprenorphine. In 5 minutes, the blood pressure was suddenly dropped to 65 by 32. Heart rate had also dropped to 45. And the pulse ox reading was 88, but the waveform was not coming very well. So we could not believe that this pulse ox reading was also correct. But there were no ECG changes, except severe bradycardia. We started on oxygen, 100% oxygen, gave atropine, mefentin. Heart rate rose from 45 to 52. Blood pressure slightly increased. The SpO2 was 92. Noradrenaline 5 microgram bolus was given. The hemodynamics improved shortly for a short time, but required a noradrenaline infusion for next 6 hours. And tropi was minimally elevated. On inquiry, we found that the patient was on alpha agonist, that is Urimax, which we was using for benign enlargement of prostate. Similar type of patient was there for cardiopulmonary CABG, and we required a very high doses of noradrenaline vasopressin for 1 hour to bring the systemic vascular resistance from 400 to around 1,000. This can happen with the drugs like alpha agonist. The next case is a full-term twins for cesarean section. Heart rate was 99, blood pressure was normal, sinus rhythm. We gave spinal anesthesia with 10 milligram of bupivacaine and 25 microgram of fentanyl in sitting position. 5 minutes, BP was not recordable. When the patient was lying down, BP was not recordable. There was no pulse ox tracing which was coming. ECG showed ventricular premature beats and bradycardia. There was no complete arrest. We gave atropine, mefentin 6+6 milligram. Nothing happened. Adrenaline, noradrenaline was not available. We gave adrenaline 10 microgram in these patients. What had happened? Basically, it was a short patient with twins. After giving spinal anesthesia and making the patient supine, the left lateral position was not given. a slight tilt of abdomen was not given. So there was a pressure on the aorta and IVC, leading to severe decrease in the venous return and all these cardiac problems. So these small things can matter. Whenever you're going to do a cesarean section, try to give a slight left tilt to the patient before, as soon as you're given spinal. Now, we always tell what is the baseline blood pressure. Do you know, if anybody knows what is the baseline blood pressure? Is it standardized? If it is the blood pressure which is taken shortly before induction, but it's a very poor surrogate because the patient will have anxiety about the surgery and anesthesia and everything. Or it's a mean of all the blood pressure, or it is the blood pressure taken at night. Most commonly used is blood pressure when the patient is in his room, in a calm condition and without stress. In multiple papers, they have suggested that you have to maintain the blood pressure within 20, You have to maintain the blood pressure within 20% of the patient's baseline pressure, the mean arterial pressure more than 65 and systolic blood pressure more than 100 to avoid myocardial and the cerebrovascular problems because of decrease in the blood pressure. And again, the same study by Martin J. London, there are multiple reasons given for intraoperative hypotension. In general anesthesia, we know IV anesthetic, the speed of injection of the drugs, the inhalation anesthetic, level of anesthesia, myocardial depression, the sympathetic blockade because of the neuroaxial block, local anesthesia, toxicity, which Madam had discussed. When we see the patient who has a high blood pressure, that means around 160 by 100, and you want to give anesthesia, what you do? You give a little bit of sedation. Once the patient sleeps off for a little bit, automatically the BP comes down. But sometimes this blood pressure can come down drastically. Hypovolemia, arrhythmias, intraoperative myocardial ischemia, severe blood loss, aortic valve compression in the pregnant patients because of the decrease in the venous return, and the drugs. The vasodilators, alpha agonists, and ACE inhibitors are the culprits for this. In one of this nice study where 326 non-cardiac patients who had MI post-operatively, 30 days post-operatively, were compared with the 326 patients in the control group, they came to a conclusion that the intraoperative hypotension increased the odds ratio for myocardial infarction by 3-folds if the blood pressure decreased by around 41 to 50 millimeters of mercury for at least 5 minutes. But if it was more than 50 millimeters of mercury lasting for more than 5 minutes, the chances of post-operative MI were more than 20-folds. In another study, a large study again, 3 lakh patients, where it was a multicentric study, where the adjusted odd ratio for the composite outcome, that is acute MI, ischemic stroke, and mortality, were checked. We found that as the mean arterial pressure decreased, the odds ratio for these complications also increased. So increase in the 30-day major adverse effect on cardiac and cardiovascular events were more as the mean arterial pressure decreased. The similar thing was given in this paper. And they suggested that the decrease in the blood pressure, baseline blood pressure of more than 20% for 10 minutes can lead to 30-day cardiac event, and decrease in the baseline blood pressure of more than 20% for 20 minutes can lead to a perioperative cardiac event. So we have to be very careful about what is the baseline blood pressure and how much down we can go. The next case is a 35-year-old male for microlaryngoscopy and laser excision of the laryngeal tumor. Simple case, no comorbidities. Injection atropine was given for as anti-sialagogue. It was given intramuscularly. All the parameters were normal. It was given ondansetron, ranitidine, Zalocort 40 milligram, and induction was with thiopentone, scoline, mask ventilation with halothane. This case was done around 15 years ago. Immediately after, when the patient was getting intubated, he had ventricular premature beats and went into ventricular fibrillation. This was the ECG which was taken. The patient had a severe ventricular fibrillation. So we called for help. CPR was started immediately. Patient was already intubated, so 100% oxygen ventilation was done. 4 anesthetists reached within 5 minutes. It was very early morning, so everybody was on the move for their cases, and they reached to that place. DC shock was given. So one more thing, in whatever setup you are there has to be a defibrillator available. This has to be a dictum that wherever you go, a defibrillator has to be there in the OT, which is working. It reverted back to the sinus rhythm. Surgery was postponed. Patient was shifted to ICU, extubated after 1 hour, and discharged the next day. Surgery was done 5 days later, and it was totally uneventful, as though nothing had happened around 5 days ago. Next case is the 85-year-old female, hypertensive diabetic, history of angina 4 to 5 years ago, for which no treatment was taken, and she was for fractured neck femur, that is DHS. ECG was what is shown here. There are supraventricular ectopics which are there, but the hemodynamics were normal. So at this age, with a few supraventricular ectopics, we don't give any antiarrhythmic to these patients. Echo showed grade 2 left ventricular diastolic dysfunction. Ejection fraction was 55%, and there was left ventricular hypertrophy, but it was not very severe. There was no MR or any other abnormality. Blood pressure was normal, saturation was fine. Humoral nerve block was given before spinal, then spinal was given with bupivacaine 1.5 cc and fentanyl. Level of block was T10. What happened? The BP came down to 80/40. Immediately mefloquine was given because that is the first drug of choice for us. The second drug of choice is noradrenaline. SpO2 with oxygen mass was 92%. ECG after 15 minutes showed this picture, where there was ST elevation in the anterior leads, and in V3 to V5, there was good amount of ST elevation. So there was a myocardial ischemia. NTG was started, and noradrenaline infusion was also titrated, giving a blood pressure of 100/50. Ventricular premature beats remained for some time. There was also some supraventricular ectopics, and the ST elevation remained. ST stabilized after 6 hours. Tropi was grossly elevated. Coronary angiography was done on day 2. The LED had 80% block with a thrombus, and RP was 70% block. The relatives and the patient refused to do any angioplasty or surgery, so he was taken on a medical line of treatment. Patient succumbed after 1 month. According to the American College of Cardiology, the myocardial ischemia is defined as acute MI, which occurs within 7 days, recent MI, which occurs between 7 days to 1 month, and history of previous MI, that is more than a month previously. And elective surgery has to be done 4 to 6 weeks after the myocardial infarction. It gives time for the heart to remodel. Myocardial ischemia, according to this paper on perioperative troponin screening, is very important because this was jointly done by the European Society, the American Society, and the World Heart Federation. They suggested that troponin level rise of more than 99 percentile, chest pain, changes, left bundle branch block, regional wall motion abnormalities, and intracoronary thrombus are the indicators for perioperative myocardial injury. The same paper suggested that the magnitude of the increase in the peak troponin level is important, and this can satisfy the MI. There are different papers for this. In one of this interesting paper where coronary angiography, he said that the coronary angiography is not a picture perfect for determining the perioperative MI pathology because postoperative analgesia masks the MI pain. ECG changes are rare. Echo was not a routine screening process, and most of the problems are because of the thrombus, not because of the plaque. So, in preoperative screening for the high-risk patients, we have to go for the revised cardiac risk index, which takes into account the ischemic heart disease, the congestive heart failure, cerebrovascular accident, then diabetes, creatinine level, and the risk of surgery. If the RCI is 0, there is 3.9% chance that patient will have risk of MI perioperatively. It was 1, 6%. If it is 2, it was 10%. If it was more than 3, it was 15%. But a better scale, what I found was the Goldman, which we use is Goldman Cardiac Risk Index, which takes into account multiple factors like age, more than 70, myocardial infarction in the past 6 months, presence of heart failure, aortic stenosis, arrhythmias, premature ventricular contraction, the metabolic changes, and the type of operation. If the score is from 0 to 5, there is 1% risk, 6 to 12, 7% risk, 13 to 25, 14% risk. And if the score was 26 to 53 points, the risk of perioperative MI was 78%. That's very high. This was what Vijay was telling about prosthetic surgery, laparoscopic surgery in a severe head-down position for a long time. This was one of our papers on steep treadmill position in laparoscopic prostatectomy. It led to a lot of congestion in the lungs. There was a confusion state in the patient because of the cerebral edema. There was congestion in the eye, and we had to ventilate this patient for 24 hours in a proper position, give them diuretics to decrease the fluid congestion in the upper part of the body, and then we could extubate this patient. The next case is a 36-year-old female for lap coal. Pre-op ECG was normal, GA was given. This was the ECG. If you see the ECG, we think that the ECG is normal. Only there is slight amount of tachycardia there, but rest of the ECG parameters are normal. After induction, so short term after induction, patient had VPBs and VT. This was the picture. We came to the diagnosis of tonsillitis de pontis. CPR was started. DC shock was given to convert it back to the sinus rhythm. Magnesium was given, 2 grams. So what is this QT interval? If you see that QT interval is from starting of the Q wave to end of the T wave. So the prolongation of the QT interval can give rise to increase in the chances of ventricular arrhythmias. What was there in our patient? If you see, I have expanded the ECG, you can see that the QT interval, that is starting of the Q wave to end of the T wave, is more than 50% of the RR interval. If that is so, then the chances of ventricular arrhythmia are very high. This can happen with the QT interval of more than 414 men, 416 women, or the QT interval more than 50% in the 50% of the RR. Different drugs can cause this, like very common drugs. The antiarrhythmics can cause increase in the QT interval, antimicrobials, antidepressant, antipsychotics, and sometimes the drugs like dolasetron can also cause. There was a black box message given by the American Society about domperidone, giving rise to increase in the QT interval and higher chances of tonsillitis de pontis. So we have to be very aware, even with ondansetron, this can happen. Our next case is a 63-year-old female with history of decreased effort tolerance, occasional palpitation, hemodynamically stable, 68 heart rate, blood pressure of 100 by 80. That is a short pulse pressure, left ventricular hypertrophy with the LAD. On echo, there was an aortic stenosis of 0.8 square centimeter and transfemoral gradient of 80 millimeters of mercury. The patient had obstructed inguinal hernia, so we had to operate. There was a plan of giving either a epidural, spinal, general anesthesia, regional anesthesia. Regional anesthesia was, that is, the block was refused by the patient. So, what to give? Our goal was to prevent bradycardia, extreme tachycardia, because it's a fixed output state, hypotension, and decrease in the RV filling or overfilling. Epidural was given, titrated dose of around 12 cc. 20 minutes later, patient had bradycardia, cardiac arrest, CPR started, could not revive. Aortic stenosis is a very, very dangerous condition if the patient has a very tight aortic stenosis, because it's a completely fixed left ventricular output. And any change, a small change in the output also can give rise to a catastrophe. So there is 13% risk in perioperative death and critical aortic stenosis with a valve area of 0.7 square centimeter or a mean gradient of 50 or a peak gradient of 80 is dangerous. One more patient was referred to ICU 3 days after laparoscopic cholecystectomy done under spinal anesthesia. We had around 4 to 5 patients way back coming to ICU with this problem. 3 days or 4 days after lap col, which was done under spinal, they came to ICU. 45-year-old female, 109 kg, 42 BMI. She came with breathlessness, chest heaviness, restlessness, and could not lie down. ECG showed RV strain, no SCT changes. Echo showed a very high RVSP, that is right ventricular systolic pressure or pulmonary hypertension. The X-ray showed lower lobe consolidation. BAPAP was started for 24 hours and patient improved after 12 hours. The BAPAP was continued for 24 hours and then stopped. So what had happened? Pneumoperitoneum with a IAP of more than 15 centimeters of water led to lower lobe collapse and atelectasis and no recruitment of the lungs because it was under spinal anesthesia and spontaneous respiration. There is increase in the pulmonary artery pressure, increase in the RV afterload, RV strain, increase the pulmonary artery pressure and the right ventricular systolic pressure, leading to pulmonary congestion and pulmonary edema. This was a very interesting case which was done in 1997 or 98. A 3-year-old female baby was there with for toe fixation. It was taken in the evening, done under general anesthesia. Procedure was totally uneventful. After giving neostigmine and glycopyrrolate, the heart rate went to 220. That was the last recorded heart rate. The pulse was not recordable. The SpO2 decreased from 100 to 70 and then not recordable because there was no pulse. There was increase in the airway pressure. Frothy secretion started coming from endotracheal tube. So the diagnosis of pulmonary edema or neostigmine-induced pulmonary edema was done. He was ventilated with 100% oxygen. Lasix 2 milligram per kg was given over a period of time. Beta lock to decrease the heart rate. As soon as the beta lock was given, we could get the pulse. The saturation started coming to around 88, 89 and slowly improved to 90s. The heart rate came down to 160. SpO2 was improved. Urine output of 1000 ml in a 3-year-old baby came in 2 to 3 hours. Patient stabilized. We could extubate the patient after around 4 hours, kept in the ICU for 24 hours. This was a neostigmine-induced pulmonary edema. The other problems which can occur, cardiac problems which can occur, are different types of arrhythmias. I'm not going to go into details of this. The anesthesia factors which can lead to arrhythmias are hypovolemia, electrolyte imbalance, sympathetic stimulation because of tracheal intubation, light plane of anesthesia, surgical incision, hypotension or hypertension, hypoxia, hypercarbia, inhalation agents like halothane, and sometimes even sevoflurane can give rise to arrhythmias, pain, drugs like epinephrine or aminophylline. Then in spinal or epidural, there is an increase in the parasympathetic activity that can lead to arrhythmias, central venous cannulation, or in cardiac surgery with CPB. There can be a narrow complex tachycardia or a broad complex tachycardia. Narrow complex tachycardia is supraventricular and broad complex tachycardia is the ventricular tachycardia. So you can get a sinus or atrial tachycardia. This is maybe because of the pain or hypovolemia or hyperthermia or something. The factors were the same. Addition of thyrotoxicosis and the thyroid crisis. You can get a multifocal atrial tachycardia, junctional tachycardia where the rhythm is starting from the AV node, or a paroxysmal atrial tachycardia. Vagotonic maneuvers can be done to control the heart rate, or even with a beta blocker. Atrial fibrillation is very common. There is 30% chance that patient is going to go into atrial fibrillation after the age of 60 or after cardiac surgery. So we are getting a lot of patients with AF, which can be controlled or uncontrolled. If the AF is new and unstable, you have to defibrillate it or not defibrillate it. We have to do a cardioversion. And if the patient is stable, then you can control the heart rate with the drugs, antiarrhythmics, and anticoagulants if required. There is a difference between cardioversion and DC shock. Cardioversion is to be given if there is a R wave, that way it is synchronized with the R wave. And DC shock is given when it is not synchronized with the R wave, it's just a shock. This is the algorithm for adult tachycardia. If there is a persistent tachyarrhythmias, then you go for a synchronized cardioversion. If this is controlled, then you go for the drugs. Other thing which can happen intraoperatively is the AV block, which can be a left ventricular bundle branch block, right bundle branch block, left anterior hemi block, left posterior hemi block, etc. So the main causes are degenerative diseases, digitalis, drug toxicity, myocarditis, and the myocardial infarction. You can get either different types of bundle branch blocks, that is LBBB or RBBB. I'm not going to go into details of this. The hemi blocks or a bifascicular block, which can be dangerous because it is a right bundle branch block with either a left anterior hemi block or left posterior hemi block. This can lead to a complete heart block. So to conclude, the crisis management is very important. And the most important thing in that is education. According to Nelson Mandela, education is the most powerful weapon which you can use to change the world and also change your approach to anesthesia. You have to be very vigilant intraoperatively, and the vigilant anesthesiologist can only pick up the problems and treat it before it causes a catastrophe. You have to be updated with the knowledge, what to do, what are the protocols for this. You have to think and act, not act and think. You have to be very calm and calculated. If you are not calm in the crisis situation, you may not give a, your approach may not be correct, and there will be more problems for the patients. Don't be afraid to call for help. Many times in private practice, it happens that if I call for help, then my work will go down, or it would look good for me, or my status will go down, or something like this. But don't be afraid to call for help. You have to train the OT personnel for the crisis management. Documentation is the key to knowledge. Why? You might have a case, sometimes if you're not documented, you will forget about it. But if you have documented the case and send as a case report to a journal, or you have documented in your hospital records, then you are again and again reminded about the problems, and you will be taking all the precautions to prevent that. Difficult times comes and goes. You can play your part efficiently. So there will be sleeping enough in the grave, according to Benjamin Franklin. Why I put this? That means you should not sleep in the OT and be vigilant and prevent all the crises. Gandhiji had told, truth is by nature self-evident. As soon as you remove the cobwebs of ignorance that it surrounds it, it shines clear. So you remove whatever your beliefs are there, that I am the best, nothing can happen if I give anesthesia or this. Just remove that. You have to be more vigilant in monitoring and towards your patients. Thank you. Can I continue with Praniti?
Yes, sir. Yes, sir. You please continue with the Praniti.
Okay. During the COVID period, there was an oxygen crisis, and we had a thought that oxygen is utilized only during inspiration and not during exhalation. So if you're giving oxygen by nasal cannula and giving it continuously, that means 2/3 of your whatever you are giving is getting waste because it's going to the atmosphere. It's not going to the patient. And second thing was there, if we can deliver that amount of oxygen to the patient with an effective pressure and flow, it can improve the ventilation, it can improve the tissue oxygenation, and open up the atherosclerotic lungs using the current equipment which is there. So we came out with a machine which we named it as Prana Niti, that is Prana Vayu Ki Niti. what we did with this was initially we checked for the FiO2 which was delivered. So with 2.5 liters inflow, that I'll tell you after the presentation is over. So this was done by Dr. Swami, Mr. Adesh Gokhale, myself.
Pran-Niti installation or setup. Pran-Niti is plugged and play with existing oxygen supply central or cylinder system and binasal cannula. Installation step 1. 1. Connect power plug at rear of machine. 2. Connect earthing connection at rear. 3. Connect oxygen at oxygen inlet of machine. Pran-Niti operations. Step 1. Power on Pran-Niti by pressing
the video, sir.
Located at rear of machine. Do not connect nasal cannula at this stage. It would be a good idea to start oxygen supply now. Step 2. Pran-Niti unit will perform its self-diagnostic steps as indicated on screen as test 1 OK and test 2 OK. Step 3. In case dry run error message is displayed, please start oxygen supply from flow meter. Step 4. Pran-Niti will display connect cannula message. Please connect nasal cannula to patient and Pran-Niti outlet. Step 5.
So at this point, it will say, give you a desired flow or what flow we have started on the flow meter that should be displayed here. Is there a difference between these two flows? That means you have kept 4 liters flow in the flow meter and you're getting only 2 liters here. That means there is some leak in the flow meter because there are almost 6 to 7 points where it can leak. So you have to correct that leak because that much amount of flow should come here. Then only the effectiveness of the machine will be there.
Pran-Niti will display oxygen input flow rate as set at flow meter. In case you need to change the input flow rate, please change at this stage and press start button. Step 6. Pressing start button will start Pran-Niti operations and will display patient's respiratory rate.
So what happened at this time is once you start breathing through the nasal cannula, the machine senses the negative pressure that is starting off your breathing. The negative pressure is sensed by the machine and it triggers off the peak inspiratory flows. It triggers off the flows from the machine, from Pran-Niti. So that we check for the time lag between your negative pressure or inspiration starting and the triggering of the sensor. And we came down to a nanosecond. So immediately, as soon as you start breathing and the negative pressure is there, it will start delivering oxygen.
And exhalation time on screen after 30 seconds. Step 7. Press output flow button to check Pran-Niti delivered output flow to patient.
Okay, if you can see that we had kept the flows which are coming from the flow meter to around 2 liters. So, but what is delivered during inspiration is around 2.5, 3 or 4 times the input flow. But this is in liters per minute. This is pure 100% oxygen which is being delivered to the nostril at the end of the binasal cannula. And because it's under a higher pressure, that is 0.6 bar, or it can go up to 1.2 to 1.8 bar also. So the pressure at which it is delivered is high. The flow rate at which it is delivered is high. And because of the Venturi effect, there will be indrawing of the air with the 100% oxygen. So we check for the FiO2. At the we attached an infant feeding tube to the agent gas monitor, the pipe tubing, and inserted through the nose to the oropharynx. And then we measured the FiO2. On the air, it was around 19% inhaled and 14% exhaled oxygen concentration in Pune. And with 6 liters of oxygen input with a venti mass, it was around 50% FiO2 inhaled and 30% exhaled. With 2.5 liters input for the Pran-Niti and delivering around 9 liters during peak inspiration, that is liters per minute. During the peak inspirative flows, the FiO2 had gone to around 0.6 to 0.75%, and exhaled oxygen concentration was around 40 to 50%. So we delivered a higher concentration of FiO2 to them. Then we started checking if we can get the cerebral and the somatic oximetry. So we checked for the somatic oximetry and it jumped from around 45 to 60 with the same flows. So the tissue oxygenation was also good.
NITI delivered
You can see the pressure is also increasing to around 1.4.
Step 8. In case you want to change input flow, please press input flow button to set required input flow and press accept. NITI safety features. NITI is equipped with.
So there are no safety features in whenever you give oxygen by ventimask or a nasal cannula. So most of the time we are seeing that the ventimask is on the head or on the chest and the oxygen is going. So it is not going to the patient, it's just getting wasted. So what we did was add the safety features
first of its kind safety features along with alarm sound and LED color change indications such as 1. No inhalation. 2. Prolonged no inhalation. 3. Dry run. 4. Power off. Let's look at each feature in details. 1. No inhalation if cannula gets disconnected or displaced or there is no inhalation by patient. Display flashes no inhalation error message along with alarm, sound and change in LED color. 2. Prolonged no inhalation. If patient does not breathe for more than 8 seconds, then every 4 seconds machine gives oxygen blast until patient is attended and alarm continues till such time. 3. Dry run. If oxygen supply stops or gets disconnected, display flashes dry run error message along with alarm sound until oxygen supply is restored. 4. Power off. In case of power failure, machine continues to supply input oxygen flow to patient, making it sure that oxygen is never discontinued to patient.
So this was the concept of Praniti, where there were some safety features. So we are given oxygen through nasal cannula, and if the patient is not breathing for more than 8 seconds, it starts giving alarm. As soon as he takes the next breath, the alarm stops. If the patient doesn't breathe for more than 8 seconds plus 4 seconds, then it will start giving a blast of oxygen every 4 seconds, so that if the cannula is there in the nose, the patient oxygen will be keep on going, and the alarm will also continue till it is attended. Then if there is no oxygen coming to the machine, it will give a dry run alarm. And the third safety feature was that if something happens and the machine stops, and there is no electricity or the battery has gone down or something like this, or something has happened in the machine, the oxygen which is coming from the flow meter will directly go to the patient, and patient won't be devoid of any oxygen. So this was the Praniti which we developed, and I use it in a lot of patients post-operatively and in preoperative patients in OSA. There's within 7 days of use, that means around 15 minutes per hour when the patient is awake, I used it. Within 7 days, the saturation, baseline saturation, which was remaining around 80-85 in severely obstructive sleep apnea patients, they came up to around 94 to 95% without oxygen on air. So we continued this for 15 days, had a PFT done again. The effort tolerance of the patient has improved, the PFT also improved, and then we could operate these patients. So we can use it in different situations, even in pregnancy. When the patient is getting delivered, that is in labor, the patient requires a lot of oxygen. So if we can deliver oxygen like this, which is increasing the tissue oxygenation, the dissolved oxygenation and the tissue oxygenation, it will have a better effect in pregnancy. This was the concept. Over to you, Manisha.
Thank you, sir. Thank you for an excellent presentation, especially with so many varied practical cases, which has covered all the points. I'll just check the chat box if there are any questions for you. I think just checking the. I think there are no questions for you, sir. It was an total excellent presentation. If all the delegates have praised all the 3 speakers primarily.
Okay, Seema, I wanted to ask Madam a question actually, if Madam is here.
Kudarkar, Madam.
Sudhakar, madam, she left, sir.
She has left, sir.
Vijay can answer this question, or anybody of you can answer this question. What is the dose of because what madam told was 1.5 milligram ml per kg of first bolus over 10 minutes, and then 15 milligram per hour, because 15 milligram per kg per hour is a very high dose. What I thought was that it is 1.5 milligram per kg. Somebody elaborate on this. Vijay, Anita, anybody? Because
Anita madam is there. Welcome, Anita madam.
I just saw her photograph. Because this was the problem, because if we give 15 milligram per kg, that means if it is a 50 kg patients, that is 750 ml per hour. That's a very high dose of intralipid.
Okay.
So it should be, I think, the 1.5, because the message to correct that it should be 1.5 milligram per kg per hour infusion.
Yeah, sir. That is what even I feel. It should be 1.5 milligram per kg per hour.
Anybody has used it, they can elaborate on this topic.
Actually, I used it and I used it like this, so it was effective. What had happened in cath lab, one patient was allergic to lignocaine, so bupivacaine was given, and you know the cardiologists give local for angiography or angioplasty. They take in a 20 cc syringe, the needle inserted, and they inject. They don't aspirate. So it went, I think so, complete 20 cc of 0.5% bupivacaine intra-arterial. And patient had immediate ECG changes and convulsion. So we started the CPR maneuver and started on intralipid. First bolus was given, then the infusion was started, and the second bolus was given after 30 minutes. And the patient...
Same dose, 1.5 milligram per kg.
1.5 milligram per kg. Yeah.
Okay. Anyone from the delegates can highlight or they can comment on this?
Vijay is there?
I think, yeah.
I think, sir, you were quite okay. When I didn't understand what did Dr. Amla say. I missed that point then.
What madam said was the dose.
1.5 is initial dose and then 15.
15 milligram per kg per hour.
Per hour is a loading dose.
Sorry, how much maintenance was?
That was a maintenance dose. Maintenance dose.
Maintenance dose, madam told, was 15 milligram per 15 ml per kg per hour.
15 ml per kg per hour. Okay. I think what I remember is it was like 1.5. Like for 50 kg patient, you would give 70 75 ml, right? And then repeat it. So by those two doses, I think mostly it should be coming back. I think infusion was, I remember, ml per kg per minute. About we usually calculate that way, like how we do in cardiac microgram. So it was around I think every 12.5. So how much was your maintenance dose? You don't give a maintenance, you just give 2 boluses.
No. I gave first bolus, then maintenance on 1.5 ml per kg per hour infusion, and second bolus of 1.5 milligram, 1.5 ml per kg after 30 minutes.
Okay. I got that. So the dose is 0.25 ml per kg per minute. It would come. So that means every minute you could give some. See, because you are losing the patient. That is what it means. So you have to try your best to get it out. And if you give, say, 0.25 ml per kg per minute, it would still mean around 10 to 12 ml per
1.5 ml per kg per sorry, 0.25 ml per kg per minute you are telling.
Yes, 0.25. That means every kg per minute, it will probably still be a huge dose, right?
Yeah, that's a huge dose.
Yeah. So to 10 ml per minute, it will be almost. So you're actually trying to give around 500 ml per hour. So that is again a huge dose.
Actually, it was what I'll go and recheck it.
Yeah, we can check it, and usually we have this put up in our report. But I think the first thing you remember is that you give 1.5 times the kg, and that means that if typically for 50 kg you remember it is a 75 ml, and then
yeah, correct.
And then hope that it recovers and give one more dose. I never had an opportunity to give it, but obviously the first thing is that you need to stock them and make sure that they are of an appropriate date of expiry.
Sir, that Prananiti is available for other members or other anesthesiologists?
We have started manufacturing it, and it is being manufactured there only near your house, near Pimpri Chinchwad.
Okay.
Because in Talegaon, we have a factory, Versa Technologies, who is one of the partners, that is Udhav Chitare. In his factory, we manufacture it. And we have sold around 25 to 30 units up till now.
Okay. And how much would be the cost?
Just now the cost is around 1 lakh rupees plus taxes. And there are more features which will be coming later on. Like I will be incorporating, once the sales starts and it is accepted well, the basic concept of Prananiti, then we'll be adding pulse ox to it also.
Okay, great, great. Wonderful.
So we showed it to YCM, the D.Y. Patil Institute also there. They also liked it, and they will be procuring it in some time, looks like.
Okay. Somebody has given the infusion dose, Dr. Kokre Pankaj, 0.25 ml per kg per minute, intralipid.
ml per kg.
That is 15 ml per kg per hour. Sir is there, he can talk, no problem. Dr. Pankaj. Okay, we can go ahead next. Sir, thank you so much. Excellent talk. Excellent presentation. Dr. Shetty, Dr. Kudalkar Madam, and Mutha sir. Over to you, Vaishali.
Dr. Vaishali.
Okay. Yes, ma'am, I'm there. On behalf of Solapur Anesthesiologist Society and Society of Anesthesiology Pimpri Chinchwad, I would like to say thank you to all our esteemed speakers today, Dr. Kudalkar Madam, HOD Anesthesia KM, Dr. Vijay Shetty Sir, HOD Anesthesia Fortis Hospital Mulund, and Dr. Sandeep Mutha Sir, Consultant Anesthesiologist and Director PAPCL. Thank you for your giving us your valuable time and very simple and basic tips, sir. I would also like to thank Dr. Manisha Katikar Madam, President MSc ISI, and Dr. Avinash Sir, Secretary MSc ISI. For
Dr. Anita Nete Madam is also there.
Yes, Dr. Anita Nete Madam and all the esteemed office bearers of MSc ISI as well as ISA for joining us together. Katikar Madam especially approving our idea and continuously giving us the positive support we needed for this jointly webinar. I would like to thank you really Maya Madam and Kavita Madam for innovating this idea and continuously supporting us, me and Seema, to organize and help us in everything. I would like to extend my thanks to Dr. Manisha Ghosh Ma'am, Secretary ISA Thane, especially for helping us getting the Jenica platform. Today we had record 195 total participants were with us. I extend my thanks to the Jenica coordinators, Varsha and Avinash, for helping us having a smooth webinar. And last but not the least, I would like to thank all the participants of today's webinar. Audience like you, that makes the presentations more interesting, awesome, and wonderful. So thank you everyone for joining us today. Thank you and good night.
Thank you, everybody.
Thank you, sir. Thank you.
Thank you,
Anita Madam.
Thank you, everyone.
Thank you, madam. Excellent job. Thank you.
It was a good one.
Yes, excellent. All the speakers and all the presentations were excellent.
It was really very good. I was hearing right from beginning. And all the speakers were sharing very good practical tips. We have heard them many times, but the choice of subject was also very good. Thank you.
We did not see you, Anita Madam, initially. Later on, I think you joined a little bit late.
Yeah, I joined slightly late. I was outside actually. And so I joined from my phone, but I was listening right from Kudalkar Madam's lecture.
Okay.
Actually,
Thank you
thanks
so
to
much.
Maya madam and Kavita madam who thought of this topic, which was hardly ever discussed in our webinars or lectures. And they didn't not only thought, they worked out it nicely.
And actually,
Yeah,
these are
yeah.
situations
Actually, this was
which
very
we
first
face
time.
daily.
And being a best friend, Kavita, so we could manage that basically. But in future also, we can manage with 2 branches. There is overcrowding of all webinars, and the delegates are getting bombarded by so many topics. So this is a good idea, I think. And we get a large number of people also, like from 2 branches, people can join. And there is no disappointment for the speakers then. Only 30 people are joining. So that becomes a little bit, because they make so much preparation. And only 20, 30 or maybe 40 people, they are joining.
Yes.
So that is really disappointing for
And
them.
here everyone
Good
has
idea.
gained something. So very nice.
Yes. Thank you so much. Thank you.
Thank
Hello,
you.
good night. See
Actually,
you.
thanks goes to
Uh-huh.
Maya. She came up with the idea, and we have a wonderful tuning. So I just could not say no. In fact, there was no chance to say no to it. So it worked out very well. I think we should go ahead with many other societies, whether you all are, friends or not. But I think you can go
Yeah,
ahead.
very true.
You can develop a new bonding.
Yeah,
We
actually,
can make the friendship with
develop a
such
new
type of
bonding.
webinars.
exactly. I was extremely shy and non-talking person, but because of this, now I know so many people from different societies. So this is nice approach for making
You
good
develop
bonds and
friends.
knowing each other, especially. Yes.
A nice one.
Yes,
So
yes.
thank you, everyone.
Thank you, ma'am. Thank you, both of you. Thank you, Seema.
Thank you, madam.
Seema.
Thank you, everyone, for
You're a good anchor.
joining.
Varsha madam, you can. Yes, thank you so much.
Okay. Good night, ma'am.
Thank you, Vaishali and Seema, for taking the efforts and making it successful.
Thanks a lot, ma'am.
Thank you. Seema, you are a
We
good
can,
anchor.
yeah.
Thank you, ma'am. Thank you so much.
Okay, goodbye.
Okay, good night, ma'am.
Yeah. Bye-bye. Good night. Good night.
I'll end the meeting. Okay.
Yes, we'll
Yeah.
leave the meeting
Okay.
outside to
No
begin.
problem.
Okay. Yeah.
Yes.